Welcome to Chapter 3, in which we will be discussing the legal formation of EMS systems. When completed with this chapter, you should be able to list and explain the primary differences between public and private EMS services in the areas of funding, oversight, and regulatory issues, analyze the strengths and weaknesses of different structural concepts for EMS services, examine the role of the EMS Medical Program Director and describe the role of the Medical Program Director in the EMS system, and describe the various EMS reimbursement systems and federal regulations on billing for ALS and BLS ambulance transports. To begin this chapter on EMS system formation, consider this situation. You are the director of a large inner-city EMS system using the fire department for first response, treatment, and transportation of patients. Your call volume has increased over the last 5 years, and your units are unable to respond to all requests for services. With this in mind, a new private ambulance company has arrived and desires to be placed on some type of response list providing transportation services to the community. As the manager of this private EMS agency, what should you do to evaluate the situation? What can you do to make this situation better for the community? This other agency could very well represent competition in your area, which could potentially impact your financial bottom line. Consider this scenario as we progress through this chapter. As an introduction to this chapter, remember that EMS is a critical component of the nation's public health system by providing first response services in the patient's continuum of care. Despite this singularity in purpose, however, there are many different delivery systems and types of EMS agencies. They can be categorized by their workforce, being volunteer, career, or a combination somewhere in between. They can be categorized by their legal status, such as private, for-profit, or public. They can also be categorized by the communities they serve, such as urban or rural. Regardless of how a service or EMS system is categorized, area needs, population served, geographical size, and the ability to deliver comprehensive services are all important in defining the EMS agency. We already discussed the history of EMS, so there is no need to go into much depth here. Remember that EMS began with Good Samaritans who aided others and evolved over time. While triage and field hospitals were developed years ago during the Napoleonic Wars, it was not until the 1960s and the publishing of the white paper that modern EMS took shape. Within a relative short period of time, improvements in technology, education, training, systems development, communication systems, and citizen education have impacted and changed EMS into the profession we recognize today. This evolution in EMS was driven by a few laws, committees, and foundations that are worthy of note. The EMS Services Development Act of 1973 designated the Department of Health, Education, and Welfare as the lead EMS agency within the federal government. The act also authorized grants to develop a comprehensive EMS system throughout the United States for feasibility studies and planning, for the establishment of initial operation of EMS systems, and for the expansion and improvement of current systems. The Omnibus Budget Reconciliation Act of 1981 restructured EMS funding and rolled it into health prevention block grants, which resulted in a decentralization of national EMS activities. Federal funding for EMS was reduced and the states assumed greater autonomy over their respective EMS systems. Given this reduction in ongoing federal support for a nationwide EMS system, foundations and institutions such as the Robert Wood Johnson Foundation made grant funds available to developing systems across the country. At the federal level today, EMS activities are managed through the National Highway Traffic Safety Administration under the Department of Transportation and other entities and organizations such as the National Association of EMS Physicians, the American Public Health Association, and the Health Resources and Services Administration have taken it upon themselves to advocate for EMS and publish standards or position statements designed to help guide the profession. As each state has a legal autonomy to run EMS as it sees fit, these nationally recognized best practices are persuasive but not mandatory or required of any state, which has left to the adoption of different EMS standards and requirements across the country. Given the variation between states, it should not be surprising to hear that there are numerous EMS delivery models employed throughout the country. Many of these various models are also employed within the state of Wisconsin. The first such delivery model to be discussed within the text is fire-based EMS. As many communities already have fire departments strategically located throughout their geographical area, utilizing the fire department to provide EMS services makes sense in many instances. Many such systems utilize firefighters who are cross-trained as EMTs or paramedics. There are also models where a separate paramedic unit that has nothing to do with the fire department may co-locate at a fire station. Some municipalities actually maintain an EMS service that is completely separate from the fire department, although some facility resources may be shared between the two municipal departments. There are also models in place where the fire department provides ALS services only and private ambulances deliver BLS care. In such systems, EMS personnel may actually ride on a fire truck, and an ambulance is provided by either other personnel within the fire department or a completely separate entity. There are also countywide systems in place. Depending on the jurisdiction, the county provides EMS services that the local municipalities either do not or cannot provide, or the county is involved in a tiered system where local agencies provide one level of EMS and the county typically provides a higher level of EMS. There are also instances where the county contracts with private services who employ civilian EMTs and paramedics. Dispatch services within the county are commonly combined in such systems, and while the textbook author refers specifically to fire and EMS dispatching, law enforcement may also be included. The textbook author also views such systems as performance-based with stringent accountability requirements, although there is nothing that precludes other services at the local level from having the same metrics, accountability, or quality of care. It is also not unusual for such countywide systems to combine fire ALS first responders with ALS-staffed private ambulances to ensure rapid response from LASETS, the fire department, and follow-up transport from a private provider. Such systems also provide for county-level oversight, which is a broader, more regional mindset that usually ensures consistent levels of care within the county. Another delivery model of EMS services include private ambulance services. These services are often for-profit companies, and there are some larger multi-state services that are actually publicly traded companies. These larger companies were usually formed from smaller services that grew, consolidated, or acquired other ambulance companies. Funding for these private services is often through patient transport fees, contracts with healthcare facilities, contracts with governmental agencies, private-public alliances, subscription services, or a combination of these mechanisms. Areas that use private ambulance services, as opposed to running with their own EMS service, may do so for many reasons, such as cost effectiveness or the desire to avoid the potential liability associated with providing medical care. The textbook also identifies what is referred to as the public utility model, where the public municipality purchases the services of a private ambulance company but maintains control over the service's operations. This model is common in some areas of the country, but not in Wisconsin. Somewhat close to the private model are hospital-based services where a hospital or healthcare organization actually provides 911 EMS response within a community. Believe it or not, how a service is formed will have a significant impact on the level of liability exposure the entity and potentially its officers and employees will have. The law as it relates to governmental immunity, statutory immunity, and entity formation can be complex and somewhat different from state to state, making the full subject well beyond the scope of this discussion. With that being said, though, there are some important points that need to be covered to help the EMS leader-manager in recognizing what type of risk exposure exists for his or her EMS agency and its employees. To begin, Wisconsin has a statute, 893.80, that deals directly with claims against governmental bodies and its officers, agents, or employees. Wisconsin Statute 893.80 sub 3 specifically caps tort damages against governmental agencies and its employees at $50,000. If the governmental entity is a volunteer fire department, that cap is reduced to $25,000. If the claim involves damages from a motor vehicle accident, the cap is $250,000 as denoted in State Statute 345.05 sub 3. The law even goes on to state in 893.80 sub 9 sub a that the procurement or maintenance of insurance does not serve as a waiver of those provisions. This is important because some states recognize what is known as the insurance waiver exception to civil liability caps. That exception holds that governmental agencies waive the statutory caps up to the limit of their insurance. Given the application of Wisconsin law, that is not the case in this state. With that being said, some may wonder why a governmental entity would then want to have any insurance at all beyond the $25,000, $50,000, or $250,000 thresholds as appropriate. The reason is because there are instances in which those civil liability caps may not apply. If a governmental employee is performing a function that requires discretion, the caps will probably apply. If performing a ministerial duty in which there is no exercise of discretion, however, the caps often will not apply. A good example is the use of both lights and siren when responding to an emergency. State law requires the use of both for an ambulance to be considered an emergency vehicle with the privilege to disregard certain traffic laws while functioning as such. As decided by the Wisconsin Supreme Court in 2013, if a firefighter or EMT is responding to an emergency call without using a siren, he or she is under a ministerial duty to stop at a red light and wait until it turns green. Because the firefighter is not in a vehicle at that point, there is no discretion on the part of the firefighter or EMT to proceed through the red light. In this case, the firefighter was not able to use state statute to have the lawsuit dismissed because the firefighter was not exercising discretion at the time of the accident. It is important to keep in mind that these civil liability protections apply only to governmental entities. This means that private ambulance services, whether they are for-profit or not-for-profit, enjoy no such protections in Wisconsin. Another factor to consider in EMS agency formation is the matter of compensation for personnel. The reason this can be an issue is because Wisconsin's Samaritan Law provides immunity from lawsuits for individuals who render emergency care at the scene of an emergency or accident in good faith. For those considered to be healthcare professionals, such as an EMS professional, the immunity does not apply if the emergency care is rendered for compensation and within the scope of the individual's usual and customary employment. The key phrase is rendered for compensation. So long as the EMS provider is not compensated, even if functioning as a member of an ambulance service, the immunity provided by State Statute 895.48 would apply. What constitutes compensation, however, is a very slippery slope that does not necessarily equate with other definitions, such as those within the Fair Labor Standards Act. As far as private ambulance services are concerned, the legal formation of the service is important as private providers do not enjoy the same civil liability protections as governmental agencies. Thus, it is important to form a legally recognized business entity that provides legal protections to the officers and employees of the EMS agency. Under application of state law, Wisconsin recognizes corporations, limited partnerships, limited liability companies, limited liability partnerships, cooperative associations, unincorporated cooperative associations, and common law trusts. Beyond business entities, it is also possible to run a business as a sole proprietor, a partnership, or an association. Utilizing one of the business entities defined by state law, however, can provide civil liability protections for the officers and principals of the business that do not typically exist for sole proprietors, partnerships, and associations. Deciding what type of business entity to form can be a complicated, fact-based decision that cannot be fully explored here. Anyone thinking about starting a new private ambulance service should consult with a business attorney to assist in determining what type of legal business entity would be best. Lastly, when discussing legal liability for services and their employees, the concept of respondeat superior must be mentioned. This doctrine holds that the master is responsible for the actions of the servant. Stated another way, so long as an employee is working within the scope of his or her employment, the employer is responsible for the employee's actions, essentially indemnifying the employee's civil liability. The crucial phase to note in this doctrine is within the scope of employment. If an employee is responsible for a civil wrong that occurred while the employee was working, but not within the scope of the individual's employment, the employer may be able to separate itself from the employee's bad actions, leaving the employee to fend for himself in the lawsuit. An example may be an EMT who uses the agency's ambulance to run personal errands that have nothing to do with the agency's operations. Just because the employee was driving one of the agency's ambulances does not automatically mean the ambulance service is responsible for the employee's actions in the event of an accident if they can show the employee was operating outside the scope of his or her employment when the accident occurred. Such a denial of responsibility on the part of the employer is based upon the specific facts of the case, and there can be a wide breadth of what is considered to be within the scope of employment for an EMS provider. Generally speaking, as an EM manager, it is important to ensure your service has clear policies, protocols, guidelines, and/or procedures to define the scope of employment, along with what activities are or are not acceptable. If the EMS service is a public employer, it may very well benefit from the civil liability caps as defined by state statute. Private, on the other hand, are not covered by those caps and have full exposure to civil liability claims. It is probably a fair guess that, for most of the general public, the availability of EMS is simply assumed. Dial 911 and an ambulance will show up. It may come as a surprise to learn, therefore, that the state of Wisconsin mandates ambulance services to be provided by towns only. Villages and cities within the state are not required to provide ambulance services. As odd of a thought as it may be, it is conceivable that a village or city in the state could, at some point, decide it can no longer afford to fund an ambulance service and simply stop providing such services. There is no state law that would prohibit that from occurring in any municipality besides a town. Regardless of whether the state requires EMS services to be provided or the delivery model employed, funding is always an important consideration. Public services are commonly supported through tax dollars, although many also supplement their budgets through fee-for-service billing. Private ambulance services may actually pay a portion of their revenues to the municipality or municipalities they serve for the right to be the exclusive EMS provider within the jurisdiction. There are other entities that are entirely based upon the fee-for-service model. Such services do not receive any tax dollars to supplement their budgets. Some of these funding mechanisms include taxes, whether it be at a countywide or local level, fee-for-service, public-private partnerships, billing of Medicare, Medicaid, or private insurance, and grant funding. It is probably important to note that there has been a shift in healthcare within the recent years to change from a fee-for-service model to a fee-for-quality or value-based purchasing model. Simply stated, Medicare is starting to question why it is paying for a single patient to be transported to a hospital multiple times within a given period of time for the same problem or ailment. The PPACA has provisions that changed Medicare payments to hospitals to refuse payments for patients who have been readmitted within 30 days for the same ailment. Medicare wants the patient treated appropriately the first time rather than simply pushed out the door only to return within weeks, days, or even hours. At some point, it may be likely that EMS will also be held to some similar reimbursement criteria by Medicare. This is definitely something EMS leaders will need to keep an eye on in the years to come. Another funding mechanism for EMS that exists in Wisconsin is the Funding Assistance Program through the Department of Health Services. Sometimes referred to as Act 102 because it was originally passed as Wisconsin Act 102 in 1989, this program distributes state funds on an annual basis to ambulance services to supplement the EMS agency's existing budgeted monies for the purposes of supporting or improving the ambulance service. Permissible expenditures included in the statute include vehicles, vehicle equipment, EMS supplies, EMS equipment, and training. Private ambulance services that are nonprofit corporations are also eligible for funds. An interesting caveat is that the funds received for training are calculated in part based upon the number of licensed EMTs on a service. The term EMT refers to the specific licensure level in state statute, not the generic reference to all EMS providers as EMTs. For the purposes of this calculation, a paramedic, intermediate, or intermediate technician is not an EMT. While funding is very important for EMS systems, so too is regulation and oversight. The government has a legitimate interest in ensuring quality medical care, which also includes medical services provided by EMS agencies. In this respect, most states have laws that require a physician, a MD or a DO, to provide medical oversight of EMS personnel. This medical program director approves patient care protocols, credentials providers, manages quality assurance and quality improvement programs, and ultimately provides oversight for the entire EMS system. We'll be discussing medical program director roles and responsibilities in a little bit. Beyond the oversight provided by a physician, most states have statutes and regulations in place that deal with EMS program implementation, oversight, funding, and management. As we already know from previous presentations, EMS in Wisconsin is governed by State Statute 256 and Administrative Rule DHS 110. While statutes and regulations commonly exist to define how EMS agencies are structured and operate, there is no one perfect model for EMS, as all structures have both benefits and disadvantages. Especially in light of an aging population, increased population density, and shifts in medical care funding, there are instances in which an EMS agency can no longer support the demand placed upon its services. This requires services to be expanded, which may include the addition of multiple services working together to provide service to a particular geographical area or region. Such a mix of services working together introduces unique variables that can make it difficult to model the same type of services elsewhere. When analyzing any type of EMS agency, the primary role for the service is typically first response. It is very common across the country for local governments to provide EMS services through their local fire departments, although there are other models, such as hospital-based, public utility, private nonprofit, private for-profit, volunteer, paid-on-call, and combinations of those models. Once initial first aid is rendered, the next function served by EMS agencies is to provide transportation of the patient to the hospital. Ultimately, providing first response services as well as hospital transport services all fall under the purview of the service's medical program director. This physician is responsible for improving the community's emergency care capabilities by offering direction and oversight of administrative, educational, and clinical actions related to all patient care activities. This medical program director should serve as the interface between the EMS agency and the larger medical community. He or she should be collaborative and cooperative with the EMS agency and its personnel. The physician must also have specialized knowledge, skills, and abilities that are not necessarily taught in medical school, as emergency medicine has evolved into a formal medical specialty with its own examining board. EMS providers serve as an extension of the medical director, functioning under his or her authority as a physician licensed within the respective state where emergency medical services are provided. The medical program director is ultimately responsible for the actions of the EMS providers functioning under his or her license. As a result, the medical program director has a vested interest in ensuring that emergency medical care is provided by competent medical professionals consistent with accepted standards. To be an effective medical program director, the physician must have frequent quality interaction with EMS providers and service leadership. The medical program director must be actively involved in the education process for all levels of EMS providers, which includes both initial and continuing education. As the field of EMS is constantly evolving, the service's medical program director must play a central role in the agency's EMS educational practices and initiatives. To summarize, the EMS medical program director must be a manager, politician, mentor, educator, and disciplinarian. The medical program director has several legal duties to the service and the public, not the least of which being that he or she is the authorizing agent for the use and control of narcotics. EMS medical program directors fill a critical role within the EMS system, and they also shoulder a tremendous amount of responsibility within that role. Within Wisconsin, DHS 110.49 Sub 2 outlines the mandatory responsibilities of an EMS service medical director. The medical director must prescribe patient care protocols under which the provider's EMS personnel deliver treatment. These protocols must be developed, reviewed, and approved in writing by the medical director as part of the service's approved operational plan. Because services may obtain online medical control from an entity that is not associated with the service's medical director, it is imperative for the medical director to ensure that physicians providing online medical control do so in a manner consistent with the service's DHS-approved patient care protocols. Ultimately, the rule requires that the service medical director ensures that all aspects of the EMS agency's operations are under medical supervision and direction at all times. This also means establishing, participating in, and ensuring the continuing implementation of a quality assurance program as part of a patient care improvement process. The service medical director is responsible for approving, limiting, or withdrawing EMS provider credentials. The service medical director must maintain relationships with the medical community to serve as a liaison between the EMS agency and hospitals, emergency departments, urgent care clinics, physicians, nurses, and other healthcare providers. These relationships also extend beyond the local area in which the EMS agency functions to the region or state, as the service medical director must ensure that standards, needs, and requirements are met and resource utilization is optimized. Lastly, ongoing education is required of both the medical director and any EMS personnel who function underneath his or her license. Therefore, the service medical director must not only remain current on the knowledge and skills appropriate for the service medical director, but the service medical director must also approve, direct, and assist in providing training activities that ensure EMS personnel are competent to provide safe and efficient patient care based upon the service's DHS-approved patient care protocols. Given this proverbial laundry list of responsibilities, not just anyone can serve as an EMS agency's medical director. DHS 110.49 Sub 1 lists qualifications that must be obtained and maintained by any person filling the role of a service medical director. These qualifications include being licensed in the state as a physician and holding certification in CPR for healthcare professionals. If the physician oversees an intermediate or paramedic service, ACLS certification is required unless the physician is board certified by the American Board of Emergency Medicine or the American Osteopathic Board of Emergency Medicine. The physician must have education, training, and experience in emergency medicine, familiarity with the design and operation of pre-hospital EMS systems, experience or training in the EMS quality improvement process, and the physician must also complete the DHS Service Medical Director course. Rule also states that DHS may prescribe other requirements as well. In addition to a medical director, each EMS service must also have someone denoted as the agency's service director as required by DHS 110.48. The service director serves as the primary contact between the EMS agency and DHS, ensures that all elements of the EMS agency's operational plan are maintained, ensures that EMS personnel are properly licensed and credentialed, and also provides the day-to-day supervision of the EMS agency's operations. Shifting gears, another critical aspect to consider when forming an EMS system is determining how the EMS system will be funded. It is common for private sector services to collect fees for service through Medicare, private insurance, or direct billing to the patient. This model is becoming increasingly popular in the public sector as well, however, as more publicly funded EMS agencies are charging for transports to offset reductions in property tax or other tax-related revenue. While public services routinely depend on taxes or subscription services to fund operations, those revenue streams are not as ample as they once used to be. They also vary between communities and municipalities. Some communities ensure a well-funded EMS service, while others have volunteer agencies that must rely on donations and pancake breakfasts to stay afloat. When considering various funding mechanisms, it can be difficult to account for all costs because services provided may not be reimbursable under Medicare, or an insurance carrier may refuse to pay above a scheduled rate. As an example, if the patient is not transported, or if the patient was transported but the transport was not considered medically necessary, Medicare will not reimburse the ambulance service. This transport requirement is making things difficult for services that are looking at entertaining the realm of community-based healthcare, where the primary goal is to actually prevent patients from being needlessly transported to a hospital. Where funding is concerned, the Patient Protection and Affordable Care Act is having quite an impact on EMS in two respects. The first is that more people have health insurance and are taking advantage of EMS services with greater frequency, that the PPACA requires emergency care, including ambulance transport, to be an essential benefit. Another interesting facet is that hospitals lose reimbursements if patients are readmitted for similar problems within a specific period of time, which has provided the impetus for some hospitals to partner with their local EMS agencies to provide community-based medical services where EMS providers literally make house calls to check up on patients. Once again, Medicare and Medicaid do not provide ambulance services for a mechanism to bill directly for medical care. Rather, they provide a transportation benefit that is paid when a patient is transported to a hospital out of medical necessity. The Centers for Medicare and Medicaid Services actually established reimbursement schedules based upon the type of transport provided and the mileage involved. Many states and insurance companies use these schedules, which further impact the financial stability of EMS services, as these reimbursement amounts do not always cover the direct and indirect costs associated with providing emergency medical care. Medicare itself has evolved into a very large social welfare program that covers approximately 100 million people in the United States, and that number is expected to increase as the population and the baby boom generation continues to age. Given the size and complexity of the program, it should come as no surprise that fraud is a significant concern. Every year, Medicare and Medicaid pays bills for medical services that were never rendered, medical equipment that is never delivered, drug plans that were not actually approved by Medicare, and so on. The scope of the problem is staggering, with the Department of Health and Human Services estimating that Medicare fraud costs taxpayers billions of dollars per year. To combat this problem, the Office of Inspector General maintains an office in the Department of Health and Human Services to protect the integrity of the HHS programs as well as the health and welfare of program beneficiaries. The HHS OIG is the largest Inspector General's office in the federal government, employing approximately 1,600 people to combat fraud, waste, and abuse within Medicare and Medicaid, while also providing oversight to more than 100 other HHS programs and child institutions, including the Centers for Disease Control and Prevention and the Food and Drug Administration. Through the OIG's efforts, $4.1 billion in fraudulent collections were actually recovered in 2011, and the FBI estimates that 3 to 10% of all healthcare billings are fraudulent. Considering that Medicare expenditures in 2011 totaled $565 billion, it is easy to see how difficult it can be to provide oversight over such a large program across such a large geographical area such as the United States. To combat fraud, the government even provides incentives of up to $1,000 for individuals who report fraud that proves to be substantiated and meets some conditions defined by HHS. Of interest to ambulance services is that the Centers for Medicare and Medicaid Services emphasize compliance in core areas for private and public sector EMS agencies. This means that reports must be signed, physician medical directors must be properly certified, transports must be medically necessary, mileage is recorded, and proper billing codes are used. It has been joked that mile for mile, it is less expensive to put a person on the moon than it is to transport someone to the hospital via ambulance. While this is obviously a gross exaggeration, I will spare you the math. It does make the point that ambulance transports are highly scrutinized by the Centers for Medicare and Medicaid Services. In 2011, Medicare paid $5.3 billion to ambulance services for transports. The impact of the PPACA, in addition to inflation and other factors, ambulance transports are big business and account for a lot of federal spending in the Medicare and Medicaid programs. As an EMS leader manager, the financial viability of your service is critical, so knowing your responsibilities under Medicare and Medicaid is a considerable necessity. Returning to our earlier scenario, what would you do? Your agency can no longer meet the demand for services. In some systems, bringing in another provider would be discouraged or not even considered. While the EMS leader manager might say too many providers would actually degrade services, such a statement is more than likely a ruse for being territorial and worried that the other system would prove to be competition for the original EMS agency. Given such a scenario, it would be your position as the EMS leader manager to figure out what role, if any, the private EMS provider would play in your community. With that being said, while you owe a duty to your employer, the ambulance service, you owe a larger duty to the public in general. It will be your job to figure out how to provide the most efficient and cost-effective services to the public served by your agency. In most instances, the person needing help does not care what it says on the side of the ambulance. That taxpayer simply wants an ambulance there quickly with trained and competent staff. It is your job to develop the positive relationships necessary to make sure your community receives the level of care it deserves and expects. Maybe it would make sense to have the public provider provide initial response and determine what type of transporting unit, BLS or ALS, is required, and then utilize the private provider to transport based upon the patient's needs. Maybe the private service provides BLS services while the public provider maintains ALS, or vice versa. Such models may actually decrease overall operational costs while increasing the level of service to the citizens. Again, as an EMS leader, it will be your responsibility to negotiate challenges like this while maintaining the integrity of your service, along with ensuring high quality levels of care to the public. In summary, there are numerous differences between private and public EMS services in funding, oversight, and regulatory issues. While the ultimate goal is to provide high-quality care and transport to sick and injured patients, there is considerable debate over which delivery method is best, and, in many instances, the right answer will vary depending upon the area and population being served. Despite any differences in delivery models, every EMS agency must have a medical program director who is ultimately responsible for the medical care provided by the EMS agency. This medical program director assumes the role of a manager, politician, mentor, educator, and disciplinarian. The roles and functions of a medical program director are numerous and multifaceted and may fluctuate somewhat from state to state. EMS agencies must also ensure adequate funding for continued operations. There are numerous mechanisms for reimbursement, and even public providers are now starting to charge for services in light of decreases from property tax revenues. With changes to reimbursement models, EMS leaders and managers are strongly encouraged to consider all possible sources of revenue to ensure the financial solvency of the EMS agency.